Evening, everyone. It's Mark Fulcher here. It's my pleasure to host you all in this afternoon's webinar, or this evening's webinar, looking at the examination of the shoulder. So if you just bear with us for a few seconds while we're waiting for people to join, we'll get started in probably about 30 seconds. So just stand by for a sec. So yeah, thanks again for joining us. This evening, we're going to be talking about shoulder problems, and it's my absolute pleasure to be joined by two other people. So we've got Rob Elliott. Rob is predominantly an upper limb surgeon who's based on the North Shore. And we've got Kimberly Wells, who is an Australian, as her singlet says. She is one of the newest doctors at Access Sports Medicine. She's come and joined us from the Australian Institute of Sport. So she's chosen a really good time to come right in the middle of a lockdown. So she's geographically isolated and properly isolated. So keep an eye out for her in Zwift. I think that's where she spends most of the time. So thanks both of you for joining us. We're going to jump around a little bit tonight, just to remind you about a couple of functions here. So the polling function we're going to use tonight, so we're going to have some voting on some cases just to get a sense for what people would do with a given case. So you'll see some of those pop up as we go. It's anonymous, but it's kind of nice to get a sense for what people are doing. The other important one to have a look at is the Q&A button. So if you do want to ask us any questions as we go, make sure you click on the Q&A button, and I may not answer straight away. But I will come back to you, and we'll do our best to answer all the questions. There is a put your hand up button asking for an opportunity to speak, but there are several hundred of us on the call, so we're probably not going to do that one. So that the best option is to send me something through the Q&A. I guess we might get started, guys. Is that okay? You ready to go, Rob and Kimberly?
Yep, absolutely.
Great.
Yep.
So I'm going to start off. I'm going to share my screen with you, and we're going to do a short introductory talk. We are going to swap around a little bit, so feel free to interact at any time. As the questions just come in, at what stage of rehab do we appreciate referrals for shoulder problems at the clinic? And I think maybe we'll be able to answer that one as we go, and it probably differs a little bit on the case. But I guess the short answer is we're happy to see patients at any time. So just jumping around a little bit, I'm going to start by bringing up PowerPoint. Which is excellent. So I'm hoping you can all see that. So what we're going to do today is to really talk about some practical tips in the ways that we will examine the shoulder. And I've encouraged Rob to chime in a little bit as we go through here. So what I do is different to what Rob does, which is probably different to what Kimberly does, and it may well be different to what you do. So I think the key thing is to have your own system. I've stolen this from Simon Young, so I'm not sure if those of you are with us tonight were also there for the knee exam, but I think this is quite an interesting way, or a good way, to think about what we're doing with our patients. And I'm going to come back to you with 4 cases towards the end of the talk, and I'm interested in getting your feedback about whether, for a given case, you want to rehab and review that patient. So treat them and see how things are going, bring them back and see how they are. Whether you're going to refer the patient to someone like Rob or myself, or whether you need to refer those patients urgently to ED. So we're going to reflect on each case for which one of those things you think that might be the best option. Like I said, totally anonymous, and it's just more to stimulate some discussion more than anything else. I guess we've laboured this point quite a bit over the last few weeks around the history being the most important part of our assessment. And I think as we talk about examining the shoulder, a lot of the tests have low sensitivity and poor specificity. So they individually are poor tests. But if you add some tests together and you have a good history and you use imaging studies in a judicious way, that's when we make a really good diagnosis. So the questions that I think probably are the most relevant with regard to shoulder patients and the patients that I see, I've written down here. And just jumping through them, obviously trauma or the absence of trauma is a really important feature. So someone who has actually had a traumatic event that they can describe is much more likely to have a major structural problem. So obviously all of our patients are well versed in telling you about trauma, but really digging down and understanding what happened. So the classic story for an AC joint problem that you all know is a fall onto the point of the shoulder. Classic history for shoulder instability is an abducted and externally rotated shoulder, as opposed to someone who has a rotator cuff problem or osteoarthritis in the AC joint, for example, where it's a much more insidious onset normally. Quantifying their function and understanding how their problem impacts them is really, really important, particularly if you're thinking about someone maybe in their 40s or 50s who may have had trauma. Understanding whether they have a full thickness rotator cuff injury that might need surgical repair, understanding the degree of function is really important. I think the site of pain can be quite helpful, mostly I think when you're thinking about things that are maybe a little bit atypical. So is the pain going down the arm? Does it go to the hand? Those things possibly are not shoulder problems. Pain that's very well localized to the superior aspect of the shoulder, that's probably you're thinking more around AC joint problems. But in general, I think that is inquiring about the site of pain is important. Severity is important, giving you a clue as to how aggressive you might be with your referral or with your early treatment. And I think a very important thing to consider is age. Types of pathology align nicely with age. So typically, if we're thinking about shoulder instability, that is most common in younger people. Understanding that that happens in young people and they have a high level of recurrence is really important. So that's important. Physiological age is also important. So you might have an 80-year-old patient who's very, very fit and active, who have an acute rotator cuff tear. Those people physiologically are quite young, and I think Rob would probably agree, they are probably worth operating on and treating more aggressively. So those are some of the things that I think are important. Rob, have you got anything you might want to add there?
No, I think that's covered it. History really does give you 80% of your diagnosis, so I think you've got a pretty good idea. Generally, common things occur commonly. So when you get someone with a very painful shoulder and they're 50 and they've got diminished range of motion, you know, frozen shoulder or calcific tendonitis is something that's going to be at the foreground of your thoughts. But yeah, you usually have a fairly good working diagnosis by the time you're taking a history like that.
Okay. So then we're going to spend a little bit of time having a look at clinical examination. But again, just looking at the patient, I think gives you a good idea. So I think we agonize over what tests we're going to do. As you'll see, the tests that I do are quite different to the tests that Rob does in some situations. I have a fairly narrow clinical exam, so I don't put a lot of stock in some of the labral tests. I just don't feel that they add too much for my patients when I examine them. But Rob will talk a little bit about his approach too. But again, we kind of categorize the patient based on what we see, what we think we can achieve out of the exam, because I think some of the things we can achieve via telehealth maybe are a little bit different, or maybe we lack a little bit of nuance when we're examining them online as opposed to in person. So I think being practical and understanding that there are some limitations. And one of the things that I was reflecting on thinking about this talk is the way I examine people with shoulder problems via telehealth is quite different to the way that I examine them in person. So when I see someone in person, I examine them and try and get them to move through a series of tasks based on the way they're standing or sitting. So I'll examine them standing, then I examine them sitting on the end of the bed, then I examine them lying supine, and then I examine them lying prone. So I think that it doesn't work quite so well for me when I'm examining people online, because they often don't have a plinth, they can't lie down. So my examination is much more focused on the pathology. So I go from different types of pathology and work through that patient exam. But again, I've developed a bit of a routine. And I think for you, the key thing to getting a good diagnosis and performing a good exam is having that routine. So what we'll do is we'll punch through some exam with Kimberly. I'm going to stop sharing my screen and get her camera up again. So every time I see that singlet, Kimberly, it just gets better.
It's good, isn't it? I knew you guys would appreciate me sporting this. Like we've just had Anzac Day, you know.
It's all
Like
in the
you're in
eye
New
of the
Zealand.
beholder. Yeah. So look, I'm going to quickly switch your video off, Rob, but I'll leave your audio on, so feel free to chime in. Actually, that really hasn't achieved very much for us, so we'll start the video again. So just if you're looking at this from home, go up to the top right-hand corner. There's a button that says Speaker View or Gallery View, and you can change what the camera looks like. So the first thing, asking the patient to be in a singlet is a really good idea, so you get a sense for what you're looking at. And you know, any clinical examination, we start off by having a look at what we can see. And Chris mentioned last time about trying to optimize what you can see by closing any curtains, not trying to have any backlit lighting, trying to get the patient to set the camera up so that they're able to move away from it. So those are all really useful and practical tips. So we've got Kimberly pretty well set up there, I think. So what I might do is get you to stand up, first of all, Kimberly, and just back up so that we can see your shoulders. So that's perfect. So I don't feel that I can see too much detail when I'm looking through people's webcams. So I'm looking for big rocks. So some of the acute injuries result in a lot of bruising, and as we'll see a little bit later on, that can be a real tell for some more significant problems. If someone's injured their AC joint, we're generally going to expect to see some swelling or deformity in the region of the AC joint. I'm going to ask you to turn side on, Kimberly. So we kind of have a general look at posture and have a look at the posture. Again, we could ask Kimberly to sit down so we can get a better look. Don't worry about it, Kimberly, but we could. So we can get a better look at her posture. Is it, she got a chin forward posture? Is she quite neutral? So she's looking pretty good there. And then if we get to turn and face away, we can have a look at scapular position to some extent, and asking the patient to abduct their arms slowly up and down. We can kind of see what's happening with scapular rhythm. We can see if there's any hitching or scapular dyskinesis. That again is gross. So I don't think we've got the same level of detail that we have when we're examining someone face to face. So I think being upfront about that and understanding that that's okay is I think important. Then what I'm going to do next is I'm going to look at the glenohumeral joint, and I'm really looking to see whether there's a restriction in range of motion. So I see a lot of people in their 40s and 50s that come in with an uncertain diagnosis, but a few months worth of shoulder pain. And I think a large proportion of them have frozen shoulder. So what I'm doing next is specifically looking for a capsular restriction. So I'm going to ask you to bring your shoulders up to the side again, and bring them up to the top of you next to your head. I'm looking for any pain or restriction. Come down again. And then I'm going to ask you to bring your thumbs up to the front. So bring your arms up in front of you. And looking for any pain or restriction. So obviously that's moving nicely and symmetrically. If people can't do that, then you get them to do some active assisted movements. So if you can grab your painful arm around the wrist with your other hand, and are you able to move through a more normal range if you use the other arm to help you? So you're able to assess a degree of active and passive range of motion there. And then what I have been doing is assessing rotation with the patient standing again. So keep your elbows tucked to your side. Can you move your arms out to the side? Can you externally rotate your shoulders? So you have a look and assess to see if there's any asymmetry between the sides. And then if you could turn side on and lift a hand up your back, how far up your back can you go? So again, so you can quantify that, I think, reasonably reliably based on scapular spine, above the scapular spine, below the scapular spine, mid-thoracic level, belt line. And I think for those patients that have quite a stiff and sore shoulder, that's probably the best way to assess their range of motion. We were talking before, and Rob has quite a good one, where essentially we ask the patient to stand side on. So if you side on and raise your elbow up to 90 degrees. And can you rotate backwards? So testing external rotation, yeah. And then can you rotate inwards? So it kind of is like a goniometer. So you can see really nicely how much rotation and quantify in a functional position. So I think that works well for, say, a younger, more athletic patient where you're trying to maybe quantify whether there's any glenohumeral internal rotation deficit or something like that, as opposed to the hand at the side and hand up the back, which I think for patients that are really quite sore and quite limited, I think that works better.
Mark, can I ask, do you quantify the degree of external rotation when their arm's by their side, or do you ask the patient to do it?
So I take a reasonably relaxed approach to this sort of thing. So I definitely want to know whether they have a restriction. And so I think when I do that, I can see, is there an asymmetry between the sides? And I think I can guesstimate pretty well. So I'm not worried about, is it 85 degrees or 75 degrees? I am interested in, is it 30 degrees less than the other side? And I feel like I can quantify that quite well. And for most of these patients with frozen shoulders, as you know, those rotation movements are some of the first to go. So I think you can usually see quite clearly whether they have a limitation or not. The other good thing about arm by side is that the rotator cuff impingement positions, you're less likely to provoke that with arm at side. So I think that those are quite a good way to look for capsular restriction. So I feel like, having done that, I've looked at the range of motion, I've looked for some capsular restriction. The next thing I'm going to do is try and do a rotator cuff assessment, and I'm going to look for cuff pathology. So we've already done that a little bit by asking them to abduct their arms and looking at their range of motion, asking about pain and trying to look for a painful arc. But I asked the patient, and one of the things that I think is really helpful is doing this and demonstrating it for them, but I'm not going to do that tonight because I think it's a bit clumsy. But I think one of the things that I found quite helpful out of last week's webinar, when Chris was examining the groin, we've clipped out the examination that he does, and I've sent that to a few patients so that they are forewarned in advance about what things they might be asked to do. And so that's maybe something that we can do with this clip as well, which might be useful to you. What I'm going to ask you to do, Kimberly, is bring your arms down to your side, turn your thumbs to the ground, bring your arms out about 30 degrees and bring them just forward a little bit. So I'm trying to get her into the scapular plane. And then I'm going to ask you to hold one arm straight and push down hard as you can with the other one. Does that reproduce any pain? Is there any sense of weakness with that? So it's obviously a little bit of a clumsy way to assess it. The other thing, sometimes just asking a patient to hold a weight in their hand. So Rob's got a bottle of wine with him. Kimberly, well done. Australian green and gold as well, I see. It's a nice look. When it's out at that full extension, we're adding more force. So potentially it's going to be more provocative. Second, can you tuck your arms into your side? Keeping your elbows tucked to your side, can you externally rotate against resistance? So can you put your hand on the outside of your hand, hold your wrist, and try and rotate outwards against your force? So you need to figure out some nice clear instructions that you can get the patient to follow. And again, showing them, I think, is really helpful. So we're testing external rotation. And then with subscapularis, I think a belly press test is quite a good way to test subscap. So we ask the patient to put their hand on their tummy. You need to bring your elbow forward. And can you push your hand into your tummy and pull it against resistance? So can you lift your hand off your tummy with the other hand? And so assessing it on the other side. The other way is asking you to back up against the wall. And you can do a push-off test. So push backwards against the wall with your hand as high up your back as you can get it. Can you push back against the wall? Does that provoke any pain or sense of weakness? So I think we can assess strength. It's probably not very gross, but I think the pickup for fairly marked weakness is probably pretty good with that. And the other thing is that certainly we can detect pain with those movements. So I feel that that is a useful test. And then I ask the patient to try and do Hawkins and Nares test. So if we're going to test, so let's test your right arm, Kimberly. What I'd like you to do is flex it up so it's at 90 degrees, bend your elbow, and with your other arm, can you push down, trying to keep your elbow in the same position. And then we can ask them to move their arm a little bit across in front of them. The other thing that I've tried is asking them to stand next to a bookcase and put their elbow on the bookcase so that their arm just hangs loose. And then so that's stabilizing the elbow to some extent. The other thing is stabilizing the scapula and shoulder by putting their other hand and letting their arm drop down. So I think that you can reproduce some impingement tests. And when I do that in the room, I do that in a variety of different positions of abduction and adduction, trying to reproduce that pain. And the other one is Nares test. So the test basically was described as forward flexing with the shoulder stabilized. So arm on your shoulder, is that painful? More recently, people do it with internally rotated, so bringing it to flexion, internal rotation. Is that provoking pain or problem? And so those two tests I find help me with impingement, and if I'm thinking about impingement and rotator cuff pathology, those are two tests that I bolt on. But again, you're just trying to paint a picture rather than putting heaps of stock on one single test. From that point, I have a look for some instability. So what I might do, Kimberly, is get you to bring your arm up to the side again. Then trying to keep your torso nice and straight, can you bring your arm back behind you? So try and keep your shoulder in the same position. Is that painful? Does that bother you? And so often patients will kind of cheat and they'll turn and lean backwards. So you're trying to really get them to be upright, and you can look at that from side on as we did before. And I guess if you are starting to see them cheating and leaning back, you're starting to think that they might have some apprehension. So that's probably still a useful test for you. I've been messing around with asking patients to do a push-up. I'm kind of wondering whether that might be a way of reproducing a posterior instability test. So you're having them on their hands and knees in a push-up position, you're just trying to see whether the posteriorly directed force is provocative for them. I'm not sure that I've found that particularly useful as yet, but I guess that's something that I've only really started with. I think that's a key take-home message is none of these tests you're going to be able to do exactly as they've been described, but you find ways that you can do them and you can kind of get them to work for you. O'Brien's test is another one. So I don't really put much stock on labral tests, but I thought I'd better show you one. So if we bring your arm up in front of you, again 90 degrees, we bring your arm across 10 degrees, and we turn it into a full thumb pointing down position, and then ask you to push down and asking for pain. And then if that's painful, and then we ask you to put your palm up and we do the same test, is that less painful? So in theory, that is a test that is provocative for labral pathology, which again, we'll ask Rob in a sec about his view on that, but I just don't feel that that really helps me too much. Two final things. I'm looking for AC joint problems. So sometimes you've obviously seen it as part of your inspection, but I ask the patient to palpate over the bony part of their shoulder. So I can usually watch them moving their fingers around saying, look, yep, that's the region I'm asking for. Does that hurt? Push quite hard. And then compare that to the other side. If I push there, is that bothering you? And then I get them to do a cross-body adduction test. So use your other arm, bring your arm across your body. Is that painful? And is that painful? So I think that's a test you can pretty reliably do. Then one of you sent me a question asking about what I do to look for potentially some referred pain from the neck. Well, the first thing is I ask about arm pain and whether they've got significant arm pain or some obvious associated neurological symptoms. So if they're talking about paresthesia or numbness or lancinating pain that goes below the elbow, then I'm starting to think about that. Then I get everyone to do a basic cervical screening exam. So look up at the ceiling. While you're looking at the ceiling, can you stay looking at the ceiling, turn your head to the left, and then turn your head to the right? So I'm just kind of doing a Sperling's test. Then can you come back to neutral? Can you look down? Any pain or problems with that? And then come back up again. Can you look over your left shoulder? And can you look over your right shoulder? So that has taken us a little while to go through, but actually in reality, I feel that that is a very quick and easy assessment to do. So I would say that that takes me less than 5 minutes to do. And I feel that it picks up most of the major things that I'm looking for. So assessment of the rotator cuff, assessment of shoulder movement, assessment for instability, and assessment for AC joint problems. And then you might bolt some things on. So if there was some instability, you might look more closely at things like Baton score. You might look more closely at their isolated shoulder external rotation. Is that more than 95 degrees? If you have a look at their shoulder abduction with their shoulder stabilized, is that more than 105 degrees? Those things are all validated tests that are associated with glenohumeral joint instability. So you can bolt things on, but they're an add-on rather than something additional. So that's what I do. Rob, is there any pearls of wisdom that you've got to add on to that?
I enjoyed that, Mark, and learned a lot. I do things a little bit differently here and there, but it's essentially very similar. it's really just it hones the powers of observation doing this. And in some ways, I find it almost easier. As you said, we talked about the goniometer sort of aspect of this, but you can almost measure it with a goniometer on the screen. And sometimes when you're assessing a patient over a period of time, I think, although we're going to be doing this for a short time, it can become apparent if you document the amount of forward elevation or abduction or internal rotation, external rotation, that you start to see diminishing amounts, and that might be a subtle sign that you've got an evolving frozen shoulder. You said that these are validated tests, and they are, but I've done a bit of a literature research, I'm sure you have, and I can't find anything on validated telehealth shoulder examination. So we're kind of learning as we go, aren't we? And we're finding what works for us and what doesn't. And I guess when we've got the benefit of scans and MRI, we can try to piece things together. It's not very scientific just because a test is painful and you have an MRI which has a finding. But it does give you some confidence. For example, O'Brien's test I have found useful to do. It's I don't pay a lot of attention to slap tears, but it certainly can be something that can cause pain. And I've found having a weight in the arm at arm length, for example, maybe a bottle of wine, and for a Job's test or for O'Brien's, we have them in a position where we call it the empty can position. And that's quite easy to demonstrate with a weight like this, 1 to 2 kg weight, or ideally a barbell. And I find that if you do drop the arm down at arm's length, that can initiate or precipitate some pain. And if you do it again, drop it, then break it, it does seem to be provocative for patients and a very limited experience who've had slap tears. So I think that's a reasonable thing to add into your examination.
Definitely picture as a Chardonnay drinker, Rob.
Well, it is winter now, isn't it? It's just starting to get cold.
Yeah. Look, I can see that.
The shoulder examination is convenient because the joint in question is so close to a head. So in the field of view for the examination, it's quite easy to demonstrate these things. I do a bit of a hip, and that is a hard exam to explain to the patient. I think it's fantastic to have an examination to send to them in advance, so you don't have to explain every single maneuver, whereas with the shoulder, because it's in our field of view, it's quite easy to demonstrate things. And particularly like to emphasize your point about looking from the front, then from the side, and then from the back, because you really can measure quite accurately, I think, the amount of elevation, forward elevation you can get. And as long as the patient's appropriately exposed, like Kimberly is, with the shoulder blade visible, you can see if they are compensating with that sagittal balance, if they're hyperlordosing, or if they're starting to rotate more through the scapulothoracic joint.
Good. I was just starting to say that I can see your questions coming through, and we will get to them. There's a couple of good comments here about doing a single arm press up against the wall with the arm flexed at 90 degrees. Might be a good way to do a posterior stability test. I think there probably would be. Another comment around using a screenshot to compare range of motion. Again, with the patient's consent, that's probably a pretty good idea. It's very similar to what you were describing, I think, Rob. So we'll come back to
talk about posterior instability. Again, non-validated test, but what I do is I ask them to forward elevate to 90 degrees and then adduct to 30, and then with the other hand again, just trying to translate the shoulder back. Now, to me, that feels as though I am actually loading it and doing a jerk test, and it's reasonably easy to demonstrate and show. But you're relying on ask the patient, is it painful, or do you feel a click or some pain? Non-validated, but I think it's fairly similar to what I do actively. But of course, I know exactly the maneuver I'm trying to create, so I do that. I think if you're doing a press up, your shoulder is more abducted, so you're probably, I'm not sure if it's exactly if it's.
Well, look, you should see me do it, Rob. It's really good.
Yeah. Well, I'll give it a go.
So look, we're going to pop back to the PowerPoint. We're going to just talk quickly about some imaging. So what I've tried to illustrate here is that there are imaging modalities, but sometimes they can be more confusing. So I think there's a really high incidence of asymptomatic findings that we need to be aware of. So I think X-rays largely are undervalued, and if you have a look at the ACC guidelines, they recommend that everybody gets an X-ray before they get their next test. And I'll quickly run through some examples where it's useful. So I think most of you would agree that an AC joint problem is a good option. So we can see here clearly that both the acromioclavicular and the coracoclavicular interval are impacted. And then this is someone with shoulder instability, and we'd see off the bottom of the glenoid, there's quite a large bony Bankart lesion, which is a pretty good predictor that things are not going to go well for that patient. This is perhaps one that you might not think, someone coming in with rotator cuff pain. This guy, there's an outlet view here, and it's a very large subacromial spur. But sometimes you'll see some calcific tendinopathy or a greater tuberosity fracture if there's been some trauma. And those things are all going to impact the way that you treat those patients. So the x-ray, I think, becomes very useful. And this one, someone that presents like a frozen shoulder, this guy's got a glenohumeral arthritis, and that is likely to be caused by his shoulder instability. And you can see some bone anchors there from previous instability procedure. Ultrasound is really readily available. I think what you need to understand with each individual picture is that you're seeing about a credit card thickness of the rotator cuff. So some full thickness tears are not as bad as you think they might be, because you're not seeing the full thickness of the rotator cuff. So when you're reading those reports, don't be too stressed out about full thickness tears. That is something you need to identify, but it may not be the significant injury that you think it might be. I love these acronyms. I try and put them into as many talks as I can. BAF stands for brainlessly applying radiologic findings, and VOMIT stands for victim of medical imaging technology. This is one paper looking at middle-aged men, essentially. So Rob and me, or Rob probably. Actually, I'm probably older than you, I think, Rob. Anyway, so almost 80% of them have some bursal thickening on ultrasound. A large percentage, 40%, have tendinopathy affecting their supraspinatus, and almost a quarter have got full thickness rotator cuff tears. So really make sure that if you're getting an ultrasound that you're interpreting it with some degree of caution, and that you're not overreacting based on the scan findings. So the other thing we've talked about in previous webinars is at the moment, to get an ultrasound, you have to spend quite a bit of time with the sonographer, and probably in the current climate, you might prefer to have an MRI scan. So MRI is the single best test. It is harder to access, definitely. And really the same issues apply. We can still brainlessly apply radiologic findings, and people can still become a victim of medical imaging technology. But I think on the whole, it's a better test and more easily interpreted. So we're going to come with some cases. We're kind of hoping that that's going to stimulate some discussion. So I'm just opening a poll here. So what we're going to do is I'm going to present a case. I'm going to send out the poll, and I'd like you to plump for rehab and review. So if you think that that's a patient that you would start some early rehab and get them back and see how you're going. The second one is referring them to someone like Rob or myself. Or the third is, this seems like a more significant problem, I'm going to refer them to the emergency department. So it's totally anonymous. There's probably not a best answer to each one, and you could argue that there's a bit of overlap, and we will. But it would be good to get a sense for what the group is thinking. So this next patient, the first patient, these are all cases I've seen since the lockdown, by the way. So they're all actual real cases that I've assessed by telehealth. So this first guy is a 19-year-old, has a physical job, and he plays a range of sports, including rugby. So that's his backstory. And this is his history. So he was diving into a pool, his arm wrenched backwards, and he had a dead feeling in his shoulder and arm. And really the main things I found when I examined him is that he had difficulty abducting his arm above 90 degrees, so his shoulder was really pretty sore. And he also was able to show me that he had some altered sensation over the lateral deltoid. And then I got an x-ray, and the report said that there was an irregularity around the inferior aspect of the glenoid. So I think that projects reasonably well. So have a look at that, have a look at the report, consider the patient information that I've given you, and I'm keen to see whether we're going to rehab or review, refer or ED refer. So if you could click on that, we'll see how we're going. So I'll give that just a couple of minutes to pop up. So while you're all voting, I'll give you the slowpokes a bit of a preview as to what actually I think we should be doing with this particular patient. And I think this is a patient that, based predominantly on the x-ray findings and some things in the history, that they probably should be referred early. And this is a patient that I would refer early to someone like Rob, because I think we can help them quite a bit. So the MRI scan here has shown quite a large glenoid fracture and other appearances consistent with a shoulder instability. And I think the key things to consider here are the dead feeling, which is a really good story with an arm being wrenched into abduction and external rotation. So often there'll be a dead sensation in the arm, and the lateral, the altered sensation, I think, is a real giveaway. But the reason I think that this is a refer early is more around the X-ray findings. So do you have a comment on that, Rob?
Yeah, I think it must have been a pretty bad dive. It sounds more like a belly flop. But yeah, I mean, it's anyone who has neurological symptoms needs to be assessed early. I think it's. I was thinking dislocation, possibly a stinger or some type of brachial plexus injury, and then that abduction external rotation type movement can be associated with a quadrilateral space type picture. But we've seen the bony Bankart fracture, so it's confirmed the diagnosis of anterior instability. And this is definitely someone you want to catch early. If there's a fracture there, then ideally for him, if it's a large single fragment, we would fix it early, and I would probably try to get him in through public system and an orifit. But it would depend. We'd do an early CT and an MRI to define that bit of bone.
Yeah. So I think the key thing there is it's not your ordinary shoulder instability. There are a few kind of red flags there that might prompt you to want to do something a little bit quicker. And so those of you that went for rehab and review, I think in general, shoulder instability is something that we can take our time with a little bit. But this particular one, I think those of you that plumped for referral are probably spot on. So I'm hoping you can share that poll. Can you see the poll, Rob?
Yes, yeah.
Did you vote?
I didn't vote, no. Did you want me to vote?
I guess that would be cheating because you've seen the case.
I personally would spend it in the ED, but that's probably not necessary. And that's, but once we had defined exactly what the nature of the injury was, and through access, we'd be able to get the MRI and CT early. It's not that common to have those done super acutely, but if it did demonstrate one large fragment, then I think we'd be best off treated with an early ORIF.
Cool. Okay, so look, case 2, 47-year-old female who's an office worker who's diabetic and recreationally active. And her problem started with a hedge trimmer. So she spent much of the day using a hedge trimmer, and she developed pain in her deltoid and upper arm that was getting worse over time. It had started waking her at night. So the main findings there was she had a restriction in all of her shoulder movements and pain with the rotator cuff testing. So those were the things that I found when I examined her. And she had an ultrasound that came with her, and she had some subdeltoid bursitis. There was a full thickness tear of her supraspinatus, and otherwise they felt that her rotator cuff was normal. There was also a normal X-ray series. So we're going to fire off that poll again. So what do people think? Is that a rehab and review, a referral, or an ED referral? And so at this stage, the overwhelming favourite is rehab and review, with a few people going refer and no one really thinking that needs to be sent to the emergency department. And I felt that maybe referral was the way to go, but I equally felt that rehab and review could be the goer. And really, I felt that referral was probably worth, or the key thing around the history is, I think, the insidious onset of pain, and the key potentially confusing thing was that the ultrasound scan findings are probably not super relevant. So rehab and review, I think, is reasonable, but I felt that because she was getting worse over time, it was affecting her pain. She's someone that I think would do really well with a steroid injection. So it could make a really big difference for her. The other thing I thought about in the current climate was she has some comorbidities. She's diabetic, which obviously also makes her more likely to get a frozen shoulder. And so maybe the presence of those comorbidities might promote a referral. So what do you think, Rob?
Yeah, absolutely. I mean, she's 47, which is fairly young for a rotator cuff tear. They do happen, and physiologically she's a bit older because of the diabetes. I think generally speaking, a younger patient probably should be referred early. If she was in her 60s, then we know at least 20% of people can have, in the 60s, who don't think they have shoulder problems, can have a full thickness rotator cuff tear, most commonly supraspinatus, 35% of 70-year-olds. So that's much more reasonable to hold on to that patient, try and rehab them, overcome this acute flare of pain that they have, At 47, she's an absolute sitter for a frozen shoulder, so that's obviously potentially a bit of overlay, and that can be incredibly painful. And they, as you say, they benefit a lot from steroid injection.
Yeah. So
I think she also needs to have a discussion at some stage, I think, with a doctor about the role of rotator cuff repair, because at 47, depending on how active she wants to be, it's a long time to deal with a defect in your cuff. It's much more tolerable, I think, as you get older and less active.
Okay, so case 3, slightly different, 32-year-old male bodybuilder who also works as a builder. So his problem started when he was doing some bench press. He felt a tearing sensation in his shoulder. He had the most significant finding when I saw him was that he had some bruising over the anterior aspect of his shoulder and arm, and a restriction in his range of motion, which he felt was mostly due to pain. So this is what this is not his shoulder, but this is what it looked like in his shoulder. So I guess with those findings, are we going to go for rehab and review, refer, or ED referral? So have a little think about that. So just while we're voting, so gee, it's happening fast. So I'd say at the moment about 60% of you are wanting to refer, 30% ED referral, and about 15% rehab and review. Do you have a comment on this one, Rob?
Yeah, for me, I would prefer to do these as quickly as possible. Most of us don't have the capacity to. It's difficult to do these guys acutely. You know, if everything lines up and you've got space on your operating list and you apply for an urgent ARTP, you could get it done within a couple of weeks maybe, but I think it's probably best for the patient to go into the public hospital and get operated on through that avenue. They're much easier to repair if you do them acutely. So personally, I would be trying to get that patient in through the public system.
Yeah. So look, I think that the key take-home message is if you see that bruising around the shoulder and arm, something bad has happened. And that particular location for bruising is very characteristic for a pec major rupture. So that patient had an MRI scan. You can see that there's a defect, or hopefully you can see that there's an area there where the tendon around the pec major is deficient. And he went and had his pec major repaired. So that is a patient that you see not often, but there's definitely one that's probably best referred quickly. In our last case here, we've got a professional sailor, 26-year-old sailor, not like a pirate or a seagoing sailor. He was a yachty. And he presented with a 4-month history of shoulder pain and weakness, and he responded or talked about not being able to do some of his work-related tasks. And really examining him, there wasn't hardly anything to find, but he just had this subjective feeling that when he examined his shoulder and when he used his shoulder, that his rotator cuff felt weak. So 4-month history, this is dominant arm as well. What are we going to do? Rehab and review or refer? So there's a bit of a mix, but the majority of you out there are thinking rehab and review, which I think is very reasonable. I think probably this patient should be referred, and I referred them on to a radiologist. And the main reasons I did that was his 4-month history of pain, which I think is a reasonably significant period for someone who relies on their arm for their job. They weren't able to do some work tasks, and they felt that it was getting worse. So I felt that with that history, it was important that I kind of try and help him with a diagnosis. And this is a patient also that I can't examine. So I feel that this is one where I'm going to phone a friend and ask a radiologist to do some work. I'm not sure why I've got case 3 again here, but this is the guy's MRI scan. So you can see there's a white round signal. I'm not sure if you can see my cursor there, but that's a paralabral cyst that is then impacting or impinging on the suprascapular nerve. And this is his infraspinatus, which with the benefit of hindsight was very weak. So he couldn't even externally rotate against resistance. So normal dense looking black muscle here, as opposed to a kind of more blobby, slightly bright signal poorly defined muscle, which you see that with denervation change. So I think totally reasonable to rehab and review, but I think there were a few things about him that made me want to investigate further and try and establish a diagnosis. So I think thinking about dominant arm, young people, prolonged symptoms, impact on work, probably those are ones that we might be referring on a bit earlier. So I might stop sharing my screen there, Rob, and we might get back to some questions. So we do have a bunch of us here. And there's some questions. So maybe I'm going to start at the bottom, maybe. What's the optimum time range for a PEC major repair, do you think, Rob?
I think within 4 weeks ideally, but the sooner you do it, the easier it is. You can starting to get a bit of scar tissue even around 3 or 4 weeks. So if you can do it within 2 weeks, I think any trauma is usually easier.
Okay. There are a few questions about corticosteroid injections, hydrodilatation, and would we be offering steroid injections in the current climate? Do you want to take that one?
They are very powerful painkillers. So in the context of a frozen shoulder, it can be extremely painful, or indeed calcific tendonitis. And if patients are really struggling, they're not able to control it. Always start with simple oral analgesia. But I think it's a relatively small systemic dose. It's a high concentration of local dose, and I think it's pretty safe, really. If it can alleviate their suffering, I don't think you'd have to have an open discussion about this potential association with immunosuppression and COVID-19, but I don't think it's been really established. Something to think about. Anti-inflammatories obviously may be associated with that as well. And if a patient is miserable, they can't sleep, they get quite stressed quite quickly. So I think it's still a valuable thing to use. In terms of hydrodilatation, I don't tend to use that unless it's a third option for a frozen shoulder. I think often the natural history is it's just starting to get better then anyway. So it gets a bit of, in my opinion, it seems to take the glory just as things are starting to become right anyway. But it's a much more invasive procedure and it's more comfortable for the patient. So I think generally a simple steroid injection is all that's required.
Yeah, look, I totally agree with you. I think my practice is I'll offer steroid injection as a kind of first line if people are interested in that. If the steroid injection doesn't work, then I'll escalate to a hydrodilatation. So that I think most people, I would say 70 to 80% get a good response from the steroid, and then the majority of the ones afterwards with the hydrodilatation, I think we pick up. So I think that maybe answers the question about the best management for a frozen shoulder. So reassurance, movement. I think the other thing I'm maybe a bit divergent to some. I really don't like aggressively working on range of motion. So I think this makes people sore. I know some of my colleagues are relatively into those things, but I think using your shoulder is normal. Our patients are often quite motivated to get better, rather than maybe the ones you see in the hospital, Rob, who are really in need of a lot of encouragement to get moving. So I feel like encouraging them to continue with their normal activity sometimes helps. Do you recommend an X-ray for every stiff or frozen shoulder to rule out a tumour?
Well, it's always good to rule out a tumour, especially if they're older or have a past history of cancer. But no, I think for a frozen shoulder, you always should exclude osteoarthritis or some sort of degenerative process, because it's already a diagnosis of exclusion. So you can see signs on an MRI or ultrasound suggestive of it, but if you have a profoundly stiff shoulder and no degenerative change, then it's essentially a frozen shoulder. So I personally like X-rays for my patients, and I find they offer a lot. X-rays in some ways a bit like the sense of smell. It shows you a history of what's going on. It shows you how the body's responding to a pathology, and as opposed to maybe an ultrasound or an MRI, which seems to be more of a snapshot of it that point in time. So when you see thickening or sclerosis or cystic change in the bone, osteopenia, signs of previous fractures, it tells you a lot about the state of the shoulder.
Yeah, I think another important point is that if you're contemplating putting a steroid injection in the shoulder, you should get an X-ray as well. So there have been a number of cases in the city that have made people look poorly by not having had an X-ray. So that's probably a good tip as well. There's a question from Bridget about how accurate and reliable ultrasound and MRI scans are for diagnosing injuries or pathology to the intra-articular portion of the long head of biceps.
not very accurate because the biceps is hard to, I'm not a radiologist obviously, but it's reasonably frequently missed because the way that MRI works, they've got to get the right planes tangential to the biceps tendon. The biceps tendon does this 90-degree turn, and it is, when you see it there, I think it's usually a real finding, but the biceps is a common pain generator in the shoulder, and I always warn patients when I'm doing cuff surgery that we have to have a plan in place for the biceps because it's not uncommon to get in there and find a very unhealthy looking biceps.
Another one, is there any role for PRP in a frozen shoulder? I would say...
I don't do that. I refer them to you for consideration, and it's definitely a conversation we have a bit. I understand it's a pain, can be a pain modulator, and that's about all I know in its role for frozen shoulder, so I'll defer that question back to you.
Yeah, I mean, that's not something that I'd consider. There's no evidence to suggest that that would be a good treatment, and I think given that the main problem is generally pain, and that for most people it's a self-limiting option, I think that's one of the cases where steroid actually has a really good role. It's predominantly an inflammatory process in the early phases, and I think it works pretty well. So I would say the answer to that is no. I'd be thinking much more along the lines of steroid. Another one, I've had recommendations from radiologists to refer for steroid into the subacromial space as a first option with frozen shoulder, as it works better. What are your thoughts on this? Is it better to go into the glenohumeral joint?
Well, majority of frozen shoulders are probably idiopathic, but there's always something that happens just before they become sore. And having a cuff tear is definitely something that can be associated with the onset of it. And if you do have a bursal-sided cuff tear, that they can linger and often end up needing to be resolved subsequently. But my first line of treatment is always going to be intra-articular. There's a paper I saw recently that suggested if you inject them through the rotator interval, it actually has a better effect, but I don't get too specific about that. I ask the guys at Axis to inject them for me, and they do very well. I think they love them. Often want to have another one. I'd say 2 on average, and by then usually the pain started to burn out. It's not going to relieve the stiffness any quicker, but it's certainly a powerful painkiller. And once you've got the diagnosis, explain the natural history, and the pain starts to pass, life becomes a lot more bearable.
Yeah, look, I would say always the glenohumeral joint in that situation. You can get some relief, and there's the papers talking about the systemic absorption of steroid. I think the radiologists, when they inject joints, they like to use CT, so maybe it's easier for them to do a subacromial injection. But I'm always a cynical guy. But I would say definitely the glenohumeral joint, you get much better pain relief, in my view. Another question about how long in a diabetic patient you'd recommend measuring blood sugars after a steroid injection. Maybe I'll take that one.
Yes, thank you.
So I think it's really important that you talk to diabetics about that. It's wildly variable. And I would suggest that in general, they up their monitoring in the first few days after an injection. And then if they've had some disruption, and sometimes it goes up, sometimes it goes down, then they usually know better than I do about how long they should measure it for. So essentially until it goes back to something that appears more like normal control. So it's not a reason not to do an injection in a diabetic, but it's certainly something you should talk to them about. There's a question about that there's a case that had the glenohumeral joint arthritis after an instability surgery. So I think the question is glenohumeral joint arthritis more common after shoulder instability and instability surgery?
Absolutely, yeah. So for starters, shoulder arthritis is very uncommon. That's about 1/50th the incidence of hip arthritis. So when you first dislocate your shoulder, your lifetime incidence or risk of arthritis jumps up a lot at that point. But then recurrent dislocations, progressive loss of either glenoid bone or cartilage will obviously increase your risk for instability. And then when we go and operate on them, we can create a different risk factor for it. Generally speaking, if it's a successful operation and they don't continue to dislocate, we'd like to think that they're protected to a degree. But if you have problems such as you over-tighten the shoulder, for example, the historical operations like the putty plat would really tighten and restrict the anterior capsule, and they used to get what we call post-capsulorrhaphy arthritis. So that was something historical, but there's still a potential risk for that if we put hardware in, such as anchors or screws. If we do a lattice and the bone block is too lateral and encroaches on the head, those things can damage the shoulder as well. So there's no doubt their risk is dramatically increased once they start dislocating, but it's not necessarily going to be removed by doing surgery. Certainly, great majority of patients will become stable afterwards, and I think that does protect them to a degree. But there is hardware, and there's always a risk for surgery that we can create a new problem.
Okay. Next question is from Oliver. It says, do you feel that the use of telehealth and not physically seeing clients affects when we should be looking for a second opinion on cases? So I'll take that one, a big, large pause. So I think, yeah. So in my view is that a problem shared is a problem halved. So I've got a much lower threshold to share my patients with my radiology colleagues. I've got a much lower threshold to send them off to see Rob or one of my orthopaedic colleagues. I think that there is a degree to which your decision making or your ability to make a decision is impacted a little bit, and in some cases quite a bit. So certainly bringing the patient back regularly, I think, is really important. And so I'm following up patients that maybe I might not have followed up if I was doing a face-to-face consultation. But I personally have a much lower threshold to refer patients on. So I'm not sure about you guys. What about you, Kimberly? You've been very quiet.
Definitely. I think there's a lot of things that we can do with telehealth, but we can't do everything. And so I think it's nice just to put a little safety net in there with making sure that people you're helping out are on the right track, using the resources of all of us, and referring. So absolutely.
Yeah. So if there's any doubt that Kimberly was actually Australian, that's probably been dispelled now.
You set me up for that.
I did, yeah. Is it possible to get a steroid injection in the shoulder during level 3? And if so, who's doing them? Do you want me to take that one as well? So Auckland Radiology Group are doing them. And I think other radiology practices are, but they like the referrals to come from a doctor. And the main reason there is around comorbidities and the conversation around a steroid injection does transiently reduce immunity. Whether that is clinically relevant or not in this situation is what we need to kind of make our decisions about. We are offering some steroid injections as well, so we're running some limited face-to-face consultations at each site. We're doing one clinic at each site per week, so it's not a huge number, and we are trying to triage those patients before they arrive. So you definitely can still get a steroid injection, and I guess my suggestion is that that's something that you think your patient might do. Just pick up the phone and talk to Rob or myself or Kimberly, and we can kind of help you with that. A question around what are our thoughts on physios in general referring for steroid injections in the shoulder? Do you want to take that one, Rob? Or
I'm a big fan of injections, and I think a lot of the things we're treating predominantly can be managed non-operatively, and if it's first about overcoming the pain, trying to use simple, safe oral analgesia is a good adjunct, but the injection is valuable if you're not winning with that. It can be detrimental effects. There's a judgment thing. If you think someone might need surgery, I personally don't want to operate on them within 3 months of the injection. It has been shown to reduce the healing rate if you're doing a rotator cuff repair. It does increase your infection risk as well. And in due course, it can soften the tendon, make the quality of the tissues poorer, and therefore the success of the surgery less likely, or increase the risk of failure. So there's a bit to weigh up. There's a bit to talk to the patient about. They can be, I think they probably take reassurance from talking to a doctor who maybe can explain the potential downsides, and then reassure them in most of the cases when it is actually appropriate, and it's probably better that they do pursue this non-operative treatment in the first instance.
Yeah, I think that those are all good points. I think one of the concerns I have sometimes is that the process is not, it's not always as robust a process. So a lot of the practices maybe aren't doing an x-ray before the injection. In some situations, the injection is being referred by a physiotherapist, is being done by a sonographer, and is being followed up by a physiotherapist. And I think that there is a degree of risk there around who is responsible for that injection, and who is prescribing the medication. So I think there are a few reasons to be cautious. In general, I don't think it's a terrible idea, but I do think that the process is really, really important. So if you are arranging an X-ray, think about, have you also got an X-ray to go with the steroid injection? Are you sure that you've got the diagnosis right? And what is the probability that the bursitis that you're seeing on the scan is actually the cause of the patient's problem? So those are probably all questions to reflect on. And again, I come back to the thing, a problem shared is a problem halved. And so it's not that you can't, it's just that sometimes it's good to get a second opinion, particularly for patients that are not getting better. Cortisone horror stories, plenty of those. The only patient that I've had a kind of deep infection ever was a rotator cuff injection that I did myself. So that was a bit of a horror story. There are certainly patients that have steroid injections. I probably see one a month that would have a steroid injection in the subacromial space, and their problem is an AC joint problem or a glenohumeral joint problem. So that whole thing around treating the patient and their problems rather than the radiologic finding, I think is really important. Any horror stories for you, Rob? Rotator cuff?
No, I have seen occasional infections in the public system. They come in and we have to wash them out. I always quote a 1 in 500 chance of infection, which I think is probably on the high side, probably closer to 1 in 1,000. But I did a literature review, and the paper with the highest rate of infection was one that quoted 1 in 500. So I think that's a safe number to quote. And again, with the regarding physios requesting it, there's a process of consent here. And although infection is probably not going to be life-threatening, it can have dramatic subsequent ramifications for their treatment. Once you've had an infection in a joint, you'll find that many orthopaedic surgeons won't want to do a joint replacement, for example, things like that. So to explain the significance of these consequences is something that's a part of a consult when you talk about it. The other thing is it's diagnostic as much as therapeutic. And I think it's sometimes we go through a course of injections into different places, for example, subacromial space or the AC joint. And I think it's critical that we have that well documented in the notes, because it really can affect the treatment they subsequently get, the type of surgery they might end up being offered.
I think that's a good point. There's another good point from Gavin. He said if a physio is referring for steroid injection, on the referral they can state if the radiologist deems it appropriate. So I think that is a way to involve a doctor. I know that there are some practices where the injection is not given by the radiologist, so it's given by a sonographer. So that's one potential problem. And the other thing is around follow-up as well. So the doctor might be acting as a technician and doing the injection, but are they examining the shoulder? Are they correlating it with the patient's symptoms, or are they treating the scan? So it's not, again, I don't really have a big position on it one way or the other, but I think if you think, what would I want? How would I want my problem treated? I think I'd probably want a more comprehensive assessment. And I'd certainly want the person doing the injection to be clear about what they were trying to achieve, rather than having them make the decision in the short period of time they have with you.
I mean, a safe strategy would be I'm not sure if physios are allowed to recommend medication or prescribe it. Obviously, paracetamol and ibuprofen, for the most part, is freely available in the supermarket. And I personally find they're both very valuable painkillers, and obviously can be used together. And I would always recommend trialing both of them together before you started going down the route of injections.
Yeah, I mean, I think that's fair. And I think just being told about the potential complications and understanding scope of practice, I think we all need to be doing that. There's a comment here around, I've been told by a doctor if you do a posterior corticosteroid injection, it will treat the bursa and the glenohumeral joint. I would say not true. Then there's one around, so I misinterpreted the question earlier about the shoulder instability surgery. So is instability surgery effective, and would you recommend it generally? So we kind of covered that, I think. So it dramatically reduces the risk of future instability, doesn't reduce the risk potentially of future glenohumeral joint arthritis.
No. Yeah, I mean, if patients are high demand or doing high risk activities such as collision sports, rugby, then it's very effective for most people. You can't make a shoulder bulletproof. It will always be able to dislocate if you subject the wrong forces to it. If you have a shoulder which is able to dislocate in extreme positions, which you're unlikely to do, and you're quite happy to sacrifice doing those type of things, then it's always best to try to avoid surgery. So thankfully, anterior instability, which is most common, doesn't tend to be painful. It only tends to be painful at the time of the acute dislocation.
Yeah, so look, another couple of comments here from Pip. I think scapular mobility and connect chain integrity are paramount in frozen shoulder, so I think it's a fair comment. There's one, in referral letters, what are the key points you like covered from physiotherapists, bearing in mind that we do have scans and reports and that we can do further testing? So are there any particular things that you like in your report, in your referrals, Rob?
I love it when you put a working diagnosis, what you think is the problem, and then summarize the history of the injury, ideally the date of the injury and the mechanism, and then summarize just salient key clinical findings that you've concerned about to support the diagnosis you've made, and then obviously run through what treatments you've done with the patient already. If a patient turns up with a rotator cuff tear, for example, and they're still sore, and you've spent 3 months with them trying to strengthen the cuff and they're just not winning, then that's a patient who's probably going to require surgery, I think.
Yeah, I think for me, I hate paperwork, and so I really like a diagnosis and a key question. So I'm not so worried about what has happened, what you've done. I'll usually talk. I think I can talk to the patient about that, and I know that we're all time poor. But it's like, do you think an MRI scan is a good idea? Do you think an injection is a good idea? Because someone told me once that when patients are sent to you, you need to do something for them and for the referrer. And sometimes that's just reassuring everybody that they're on the right track and that it is going to take longer. But it's really nice to know what it is that you're after. So for me personally, I think for a lot of the guys, we're not really needing everything. Don't feel like you have to do a massive long letter. But I think, as Rob says, the key points. And the other thing, a daily frustration for me, first world problem, is where was the imaging done? Because I can find it if I know. My nemesis is Lincoln Road. I think there's 5 radiology practices on Lincoln Road. And patients, they never know where it happened. So was it TRG, ARG? They don't really know what G it was.
Yeah, expectations is a big one as well. What the patient is pushing for. If they feel as though they're determined to avoid surgery but are worried they might be missing something, then that's helpful. If a patient is sort of expressing a desire that they want to have something repaired or fixed, it's also good to know and whether or not the physio feels as though that the patient is a suitable candidate in their mind for going through a surgery and the rehab.
Yeah. So look, I am very conscious that we've gone over a little bit over an hour, so I totally understand if people want to move on, but there are still a few questions coming through. So we might keep answering them. If you're interested, feel free to stay. We're going to try and do something a little bit different next week. We're going to try and do a sports medicine quiz. So I don't know if you've been mucking around with Zoom. I'm sure you have, but there's an option to split this group into small subgroups. So we're encouraging people to join with a team. You can spend some time answering the questions in your team and then come back into the group. So we're hoping that might work quite well. So look out for the sports medicine quiz. There's not really going to be a lot of sports medicine in it. There'll be some, but I think it'll be a good opportunity, I think, to interact with everybody. So that's going to be next Thursday. Keep an eye out for that. And then we'll try and do a webinar on Tuesday. So just a few more questions, Rob. We might as well punch through these, I think. Unless you got somewhere else to go.
No, nowhere to go. No,
surprising that. So MRI versus MRI arthrogram for SLAP lesions?
I think the arthrogram is more sensitive. Any type of labral pathology, I would ask for an arthrogram. Unfortunately, at the moment, we can't get them because it's deemed to be too invasive during COVID-19, but that will pass.
Yeah, I think the other thing to consider is how much you want to look for SLAP lesions. So I think the indication maybe for treating those is becoming less and less over time. Would you say?
Yeah, I'll take that with a grain of salt. A slap tear, I'm not going to be rushing into doing it. I think very, very rare to need to have a slap repair these days, but they can cause pain. A substantial type 2 slap tear and tears or bucket handle tears of the superior labrum, they shouldn't necessarily be ignored, but I think they're probably they're very prevalent and they're not always symptomatic. And if you're fishing for something that's causing pain, you can't quite put your finger on it, then I think that's, if you think it's labral based, then an arthrogram will be more sensitive.
And a question about return to activity and rehab after an injection. So do you have any specific recommendations that you give your patients?
Personally, I would recommend a week of rest. Want to control the pain, get the patient on top of their symptoms. And for example, there's a bursitis or a rotator cuff tear, and then I'd ask them to gradually get back to see their physio and get back into their strengthening. I view it as giving a window of opportunity, and we really want to control that pain as much as possible so they can get on with their strengthening, and hopefully over that period of time will change the natural history of their symptoms.
I think that's the key message. It's a facilitator of the rehab. So the things that you've likely been trying to get them to do for the last month or two before they've had an injection, the reason to do the injection is to get them to do that again. So it's not a reason to go back to playing squash or I don't know, whatever they might be doing. What's the best way to ensure access can see radiology reports? So in general, as long as we know where the imaging was done, we can find it and we can see the reports. There are a few exceptions around town, but by and large, if you just note or make sure the patient understands where the practice is, we'll be able to find it. Would you say, guys?
Yeah, definitely need to know all we need to know is which practice it was done.
Yeah, Anya's made a good point here around how Access always wins the quiz night. So I imagine, seeing as we're hosting it, we'll probably win it as well, I'd say. So we'll have some teams. We actually won't have any teams, but anyway. Then I think we're kind of rolling it up. So there's an interesting case, it sounds like, around a telehealth consultation with acute localized swelling at the anterior aspect of the glenohumeral joint that was only there on waking. It was excruciating. A young, very fit guy who was given prednisone. Is that usual? I would say not usual. Sounds odd. So the morning pain and maybe swelling maybe infers some form of inflammatory process, but certainly I would be looking for some more imaging or a blood test or evaluation before prescribing prednisone. So I saw a patient, again, on lockdown. I couldn't get my telehealth portal to work, so I was on the phone. This is one of my crowning moments of medicine. I diagnosed polymyalgia rheumatica in a challenging phone consultation, but that's typically a problem that starts in people in their 50s or 60s probably, and they get a lot of stiffness and pain, predominantly the axial skeleton. So he was referred with hip pain, but he also had back pain and pain in his other hips, and he had sore shoulders. And those guys do really well with prednisone. But before I did that, I had got some x-rays and I got some blood tests which showed an elevated ESR and CRP, which are some measures of inflammation. And I did also get an MRI scan of his lumbar spine, because his predominant symptom, talking with him, was back pain and some leg referred pain. And you just, again, I think they call polymyalgia rheumatica the great imitator, or is that syphilis? I can't remember. One of those. And so it is a diagnosis of exclusion. So you want to make sure that you're not missing things. So steroid not widely used, particularly in young people with no clear diagnosis, I would say. And maybe one or two more. So if you see a patient with neurologic symptoms, how would you assess that via telehealth? Or would that just be a red flag suggesting they need imaging? What do you reckon, Rob?
Well, you obviously want to find out whether or not I've got neck pain, and you go through your neck range of motion exercises, like you range of motion assessment like you did, looking for radicular pain. Asking the history will often be very suggestive. So, classically shoulder pain is localized to around the anterolateral aspect of the shoulder, classically radiating down to the deltoid insertion. But as you see, if it goes below the elbow, I'm starting to get very suspicious about the neck. And then you ask for associated symptoms, particularly paresthesia. And I think it's reasonably easy to ask the patient or to demonstrate areas, the autonomous regions for the dermatomes that you want to look for numbness. If you're trying to assess potential radiculopathy from the neck, you're looking for nerve root distribution versus a peripheral nerve lesion. For example, carpal tunnel might be the radial border of the ring finger through to the thumb. And so I think that's a reasonably easy thing to do. Obviously, reflexes you can't do, and strength is, you can do it very grossly from probably against gravity to normal, but it's a gross assessment anyway.
Yeah, I think the other thing that I would mention there is that I find that patients with frozen shoulder often have random symptoms, and it's not uncommon to have pain referring below the elbow and to have some form of paresthesia. So I totally agree with what you're saying. I think you want to look closely and think closely about what's going on. But in that situation, I see they've got a restricted shoulder range of motion. Then I've got a fairly low threshold to go after that rather than worrying too much about the neck. But that's just something that I've just observed in my practice over time. I'm not sure whether you've got any comment about that, Rob.
I guess it depends on the etiology of the frozen shoulder. There is, there's a shoulder hand syndrome that patients can get, where they can get almost a chronic regional pain syndrome in the hand and a stiff shoulder. So it's something that's associated. But yes, I mean, frozen shoulder can be, and the symptoms of it can be quite broad until it starts to define itself. It's often severe pain early on, and you're wondering what's going on. I get the benefit of often seeing them after a couple of different healthcare professionals have seen them. By that stage, it's stiff and it's reasonably obvious for me, but I don't think it's as obvious when it first develops. Yeah,
it's very easy to be the smart guy when you're the last guy. I think that's something that we're really aware of, and we're really lucky in that we often can learn from what hasn't worked well for other people. Maybe last question is from Carmen. Have you got any specific suggestions for testing scapulothoracic function? Save the trickiest one for last.
Often it's predominantly observational anyway, and I think as long as you've got good lighting and the patient's appropriately exposed, so you can see with Kimberly when she did her examination, the singlet was exposing the medial border of the scapula, so it was reasonably easy to see it. Otherwise a sports bra or a man you have them topless, and you're comparing symmetry and dyskinesia or jerky motion. Often, if there is a snapping scapula, which is a pretty rare condition, you get an audible sound. It resonates in the chest cavity. And so your patients may be able to describe that. They can often, it's often audible within a room. I've not seen one via telehealth, but it's something you can ask about. There's different French words that describe the resonance or the tone of a snap. But the patient, if you ask them about it, will often say, yes, no, it is quite a hollow, kind of echoey sort of sound.
It sounds like not.
And just observing from the front and from the back and the side, I think gives you a lot of information. But it doesn't substitute for trying to, to put your hand on to feel flat crepitus.
Yeah, that's right. If you're talking about non-validated signs, I think the French word for it, the noise that your scapula makes when it snaps, that might be not validated. But anyway, it'd be good to know what it was. That might be.
It's cross. I'm not French, obviously, but it's frosmont or crossmont or.
That's definitely going in the quiz for
I'm making it up, but there is 3 different sounds described that are made by snapping.
And so maybe one last question, because it looks like Monique maybe put it in the wrong place and I ignored it. So impingement and frozen shoulder seem to present very similarly. How common is it for impingement to turn into frozen shoulder? It definitely is something that can happen, right? So as you say, there are a lot of these patients that start with a sore shoulder and then it becomes stiff, and it's really moot. Who would really know what was the initial cause of the pain, whether it was an early frozen shoulder that just hadn't gotten stiff yet, or whether it was impingement that became stiffness. I think the key thing to understand is if the pain's getting worse over time and you start to notice that it's associated with stiffness, you probably need to reconsider your diagnosis. So I say to patients, there's 2 reasons why you're not getting better. One is we got the problem wrong. The other is that you've got the treatment wrong. And I think it's always good to reflect back on whether you're confident that your diagnosis is right. So it may just be that it's a painful shoulder that was a frozen shoulder at the beginning. It didn't look like it. You have anything to add to that?
Yeah, I mean, I do think it's they can be precipitated by these bursal or cuff problems. And as I said, the bursal sided tear is one that I just think has a lower probability of doing well without surgery. It does seem to be associated with more of a mechanical type of impingement. Even though you think that the environment would be better for healing being on the outside of the shoulder rather than the inside of the shoulder. So that's a tough one for the patient to swallow, going through that whole natural history of a frozen shoulder, waiting for it to start moving again, and then to still have that impingement pain at the end of it, which may need surgery.
Cool. Well, look, thank you all for joining us, and particularly, especially thanks to you, Rob, and thanks to you, Kimberly, for joining us and your contributions. Look, I hope everyone's going well out there, and look forward to joining you hopefully next week, either at our webinar next week or potentially for a quiz. So thanks, Gavin, also for laughing at my jokes, albeit virtually. So we'll catch up with you next week, and thanks again, guys.
Thanks, Mark. See you, everyone.
Cheers.